What's up, everybody? Welcome to the J3U podcast with me as co-host Luke Miller. What up, Luke?
Not much. Just trying to get this podcast done before you hit the end button on
I
it.
didn't sleep a lot last night, so yeah, I'm just kind of hazy a little bit. My mind's working though. With our conversation right before this, I was clicking enough.
You were clicking well. You were clicking well.
Well, anyway, guys,
yeah.
we wanted to dive into fat loss agents, their deployment, when along the spectrum of off season, mainly prep that you're going to be deploying these things. So, and maybe touch a little bit on cardio if we do get into it.
Yeah, if we have the time. If not, we'll
Yeah.
do it prep episode. But I think kind of like we had talked before, like maybe just starting with the ones that are going to be kind of in play on the forefront and kind of like going through an order of deployment across the contest prep. And if there's any like prerequisite information for any of these that we would want, then kind of diving through that. But I think the first two are kind of ones that are in play already at the start of prep for a lot of people.
Yeah, it's along moving into a contest prep, it's trying to pull down on the big levers first and pull out as much fat loss as you can with the least imposing to like fatigue, and making also the prep feel the least burdensome possible, right? So at the start of a prep, fat loss should be pretty easy to pull some out of with just food drop, and that's primarily the first move that I go to. But the agents that we'll probably already have in hand that are already aiding along this process in an enhanced user, this could be female or male, would be growth hormone for one. And I would usually have this timing adjustments according to actual growth hormones action over IGF-1.
Yep.
What we're deploying for in the off season.
Yeah, which would kind of have us moving one of those administrations into like a fasted AM growth hormone administration, where like during the off season, a lot of times we'll see it kind of just given throughout the day. I'll even sometimes, even though it's maybe not necessarily to drive like the fat loss in the off season setting, just do it from an ease of adherence setting, like doing it first thing in the morning if they're working all day. But I think that's probably the big move with growth hormone is like understanding and this is kind of why I brought up the cardio modality when we were originally talking about it, was that people always discuss, does fasted cardio matter versus non-fasted cardio? And it's like, well, in general, probably not. But if we do have these lipolytics in play that are going to aid in fat loss in a fasted state, it is probably important to get some sort of activity for mobilization while these are in play, which is kind of where we kind of start the growth hormone conversation, and why I do think that we see within the enhanced world the importance of some sort of fasted cardio, even if it's not all of it.
Yeah, I used to think, I was with amongst the bros and we're just like, fasted cardio is like the secret to just burning body fat solely. And then, it's, you didn't worry about as far as like muscle breakdown or anything, or what if you wouldn't want to do it like in the fed state, because then you're not going to burn body fat. And looking through some data, if you are at a fast state, you burn more body fat, you burn more fats during, but the rest of the day you might burn more carbohydrate, or vice versa. Actually, if you have more carbohydrate while you're doing cardio, maybe you would burn a little bit more carbohydrate during, but you might burn more fat the rest of the day. So it kind of all evens out. But there is a clear advantage, I think, when you are enhanced and you can deploy some of these agents that take advantage and work well in the fasted state. So with growth hormone's main action is mobilization of fatty acids from adipocytes. So it's liberating fatty acids into the bloodstream, but you still have to do something with them. So you then need to do some type of cardio, or just big picture for the day, you need to be in a calorie deficit. So deploying it in that setting in the off season, if you're not in a calorie deficit, growth hormone is not going to have its main actions. You're going to mobilize fatty acids if you took it fast in the morning, but it won't have the benefit because you're not in a deficit total for the day. So that's usually when we're deploying it at nighttime, when it has high bioavailability, or around training, or if you have multiple doses, maybe one of those would be in the morning. But when we move into that prep state, doing cardio in the morning, growth hormone first thing in the morning makes a lot of sense there to have that dose. So there's a transition, and we would use that dosing then.
Yep, for sure. I think that kind of brings us to the other one that's popularly being used right now is like the injectable L-Carnitine. Yeah.
Yeah. I used this in like long
Also,
time ago for a lot of people had been using it. That was in 2015.
oh yeah.
Used injectable L-Carnitine, a good amount of it too. I think it was like doing a 2,000 milligrams of
Ooh,
it before
wow.
cardio. It was split, so it was like before cardio and before weight training, and it was like it was so many shots. I just like forget this. That it's like at that point you're like, oh, whatever, you just do what it takes. Like, yeah, this was like so many insulin pins that I was just like, forget this. This was like not worth it. And I was absolutely peeled anyway
Yeah.
from everything else in place. So like I dropped it because my adherence, I'd be honest, my adherence sucked on it because it was just too much to do.
Yeah.
But circle back around, it's kind of repopularized as just, everything else that we could pull out to gain like 0.5%, or lose 0.5%. But
Yep.
so yeah, with L-Carnitine, and just to clear up some things with it, a lot of people do take it. Well, for one, it's actions, right? I think that's important to just lay out
Yeah.
how it works, so you
Basic
know
act.
how to even deploy it.
Yeah.
And carnitine, there's an enzyme that is responsible for transfer of fatty acids into the mitochondria for oxidation. So just cardio training alone, part of the adaptation is increased expression for this enzyme, and carnitine is a part of it. And
Mm,
so if you're consuming adequate amino acids and have enough dietary carnitine, you already have probably a baseline high enough level of carnitine to where this is never a limiting factor. So a lot of people taking carnitine, it's not going to make you burn more fat. That's not how it works. Now, people also have carnitine deficiencies, and where they don't have enough carnitine, and adding in carnitine, they end up utilizing more fatty acids and losing body fat. So that's a situation where that would happen. In a contest prep setting, it might be likely that we don't consume enough carnitine while we're on a prep. But there's also some added other benefits along with it too, that it could help with ammonia cycling and improving performance and also improving recovery. So there could be some benefits around resistance training as well.
yep.
That's kind of the short and sweet on it. Deployment, it does have to be uptaken by the muscle. So it
Yep.
is, you need insulin present to do so. So then you have people like, well, I'm going to inject insulin and take carnitine before I do cardio. It's like, yeah, I guess, but just a bad idea. Like, and because if you think about this, carnitine is going to build up in the muscle with this enzyme present. So it's,
Yep.
you don't necessarily need this immediate right before cardio. You just need a good time to uptake it and build up your levels in the muscle. And I would say the best time to use it would be before resistance training. When you have your pre-workout meal, you'll have the advantage for during training for aiding recovery, but also you'll still have it in place when you wake up in the morning to do your cardio for enhancing the fat loss process. But it's more so in the transfer of these fatty acids, not necessarily in making you burn more fatty acids.
Yeah. One thing we didn't do with growth, we probably can touch on this because this is a question we're going to get asked, is like dosing for L-Carnitine and growth hormone, as far as like where we're using that with individuals, just within like a fat loss type of a thought. I think on growth for me, like most of my guys, first shot in the morning is going to be 1 to 2 IUs, depending on how much their total is for the day. So like commonly it'll be between 3 and 4. So typically it's either, if it's 4, it's like 2 administrations or 3. If it's the 2, then it's the 2 and 2. If it's 3, then I'm probably going 1, 1 and 2. So just kind of depending on how you're splitting up your growth hormone dosing. And then on the L-Carnitine, a lot of my guys and girls are around like the 250, 300 milligram mark, but don't know what your thoughts on dosing that would be.
Yeah. So, I mean, you could take it orally. You absolutely could, because it looks like 2 to 3 grams orally could have application, but it does have pretty poor bioavailability. And it's almost, people could argue it's kind of wasteful to even try to do it that way.
Yeah.
There's also might be an issue with it getting converted to a little bit more of a toxic compound. And so injectable would really preferentially be the way to go. I've used it orally in some for different reasons. But as far as what we're talking about here, injectable around that 200 to 300 milligram mark, because you do see so much improvement in uptake that way, is a good dosage. And if you look at some of the data like around carnitine, it could be higher, but I guess keep in mind that we're trying to use this in a polypharmacy approach to where we're pulling on multiple levers to bring about fat loss, rather than just, hey, we're only going to use L-carnitine to drive this fat loss process. And then we might drive up that dosage more. But being part of a model where we're using multiple compounds, we wouldn't need quite as much of each one and try to pull the least, pull the most out of the least, right?
Yeah,
so,
sure.
Yeah, so I agree. I think that's a good dosage point around it. And to be clear too, you don't need to take exogenous insulin with L-carnitine pre-workout. Your endogenous, the insulin you're going to produce on your own is completely adequate to do so. So don't think you need to be doing that on a contest prep.
Yeah, for sure. For sure. I think that kind of brings us to our good friend Clenbuterol.
Yeah. You want to do Clen or thyroid?
Thyroid. Let's thyroid first,
because it can
be so variable depending on the presentation of the client.
Sure.
Right? Which I think is an important context to add here is like when we're looking at thyroid deployment, a lot of times this needs to be under the context of lab work and where that's trending. We can kind of use symptomology to suggest, subjective symptomology to suggest testing, but we also have crossover in that symptomology to other things. So it's typically smart to make sure we're testing and double checking to see, is it actually thyroid adaptation, right? And I think this is one that I can't stand, but thyroid adaptation is not just is T3, T4 low. We can also see like thyroid compensation where we see large increases in TSH, but then T3 and T4 are kind of moderately similar or a little bit lower, which is like that compensated thyroid. And so we need to be checking these thyroid panels in the off season as well, just to kind of see where we're at. And if permanent thyroid implementation is something that needs to be done, possibly through a medical practitioner for that athlete before we even get into the contest prep deployment of that.
Yeah, I think, for that, it's timing your labs and to where they're kind of already, you have a rough idea. And that's usually how I do it. So right before we start prep, we're usually pulling labs. Say it's a 20-week prep, then right in the middle of prep, we pull labs again, which is probably around the point when you're starting to dig a little harder and getting to like, sub 10 weeks out, you are getting to body fat levels that are probably getting more extreme, and there's plenty of adaptations present. So you could pull them around that time point to really get a gauge. But I think you'll also get some insight pulling them in the beginning of a prep too, to see where someone's baseline at. And on prep, they're not going to be improving. Highly unlikely. Almost every study we look at, there's thyroid reduction, and so that should give you some insight. But I think subjectively, like you said, some of the symptoms that we might be seeing, it's tough because it can get murkied with the other aspects, because usually there's like fatigue being driven up, and that could be around low thyroid. There could also be just issues around, you usually see GI issues. Thyroid has a big role in peristalsis, and you might see constipation starting form. But even then, the other adaptations you're seeing from prep are also probably thyroid being dropped off at the same time. So when you're seeing like sleep disruption, all the normal issues you see with prep, that's probably at the same time thyroid might be off. It's usually also when you push someone a little bit harder and you see that fight back start to happen and that resistance, that's usually when thyroid's getting compensated some. But around that too is you when you also like, hey, how else can I manage this prep to where you're not getting so much of that fight back when you're pushing someone a little harder, but being in the enhanced side, we have the advantage to, replace at physiological levels thyroid if it's starting to get low. Why would you not? If it'd be like saying, hey, we're going to prep and we're not going to replace testosterone. We're just going to let it drop off. Like, well, that's crazy. Why would we do that? Like in bodybuilding, that's what we use anabolics for. It's like the same with thyroid. I feel like people are a little bit more resistant to thyroid implementation. I think maybe it's because around the risk of thinking like you're going to ruin your thyroid, because there's a lot of that happens a lot, right? And we see that, but it's not from thyroid usage necessarily. I think a lot of it's around just chronic dieting.
Yeah, I think that gets conflated too, because there is thyroid abuse, right, with like using dosing that's way too high. But I think for a lot of people, just running somewhere around replacement dose is probably going to be the peak of where you're going to have someone as they adapt over a prep. Like I haven't had a prep go over 37 and a half this entire last year. So I think that just kind of gives context on like, where do we start to draw the line on like abuse possibly, but also understanding like, are you giving the time on the chronic dieting standpoint to actually recover from prep, where we're not on the next prep having to bring it in that much sooner because it's just like this lack of restoration that occurs.
Yeah. And I would lean towards bringing it in. Sometimes the labs don't happen, I'll be honest, like it doesn't always happen. I would lean more towards bringing it in earlier than trying to wait for these labs and waiting for like to see all the fatigue symptoms, because we can just replace it and make sure you're around physiological. Same like with using anabolics, right? Because weigh out the risk there. Like we have research looking at thyroid replacement for 10 years and stopping thyroid hormone, and these individuals restart thyroid production within a normal range relatively quickly. So this isn't an issue of like, oh, if I start thyroid too soon, it's going to ruin my thyroid function. No, actually, I feel like people have a better time coming on off the back end of a prep, not having such a low thyroid output.
I agree.
So, and then, oh, well, I'll get into that in a second, but like leaving a little bit in until you're in a good spot where you can actually recover thyroid function post-show.
Yeah.
So that's what I would lean more towards bringing it in if I need to, but because I'm bringing it in at dosages that are close around replacement and within prep, and what's close to replacement. Well, like you said, Luke, typically it's like 25 micrograms of T3. For some, it might be up to 37.5. And why I lean a little bit more to T3 in a prep.
I was going to ask that because I get that asked a lot. Mono versus dual therapy.
Yeah. Well, with normal like thyroid replacement, hypothyroidism, not talking contest prep, it usually is monotherapy of T4. So you have your own control of conversion to T3 in peripheral tissue. Now, in a contest prep setting, there's a decrease in conversion of T4 to T3. And so you're already becoming less effective in that conversion process just through the dieting aspect. So T3 deployment makes a bit more sense, I think, on contest prep. However, this isn't something I would carry out if you actually need it, like in an off-season setting. A mono or even a co-therapy T4 T3 mix, people just subjectively tend to feel better on. And there's a study looking at this, like co-therapy versus monotherapy. Outcome is relatively the same, but most people have had better just subjective feelings of wellness using a dual therapy. So that mix of T4 T3.
Yep.
So that's what I would transition people to when we move post show, is moving into like T4 T3 combo. But in prep, I'll mainly stick with just using T3.
Yeah, for sure.
And keeping them close within the normal range, right?
Yeah. No need to go super physiological with thyroid hormone. That's just,
and I would say like
more issues.
Going that high, like what I'm seeing people on 100 micrograms of T3 a day, and T3 drives all metabolic processes, right? So it's going to, it can support anabolism. It also will be catabolic as well. So it does drive catabolic processes. So if you go up high enough, it absolutely will drive more tissue breakdown. And so you don't want to drive it up that high. I would just try to keep yourself in that relatively high normal range.
Agreed. Trying to think if there's anything else on that. I think the big thing is like if labs are possible, it is nice, but we can be a little bit predictive with it, and kind of understanding that it is going to be needed. And then some of the long-term data kind of lowers some of the warning and the risk. So as a coach, if you're communicating with an athlete that's like really worried about it, maybe sharing some of this data is a good way to create that buy-in so that they can understand the risk that is there, but that it's maybe not quite as bad as it's pervade in the gossip circles of bodybuilding, for lack of a better term.
Yeah. And like, with that, make sure you are supporting every bit of thyroid function that you can. So a lot of those enzymes are dependent on selenium and iodine. So you want to make sure like you provide that, because a lot of times we're just using non-iodized sea salt in bodybuilding. So having some type of source for iodine, because that's important for thyroid production. Then even selenium is going to be important for the enzymes that convert T4 to T3. So providing some of those basics are important, then even providing a lot of your adaptogens that help with stress management would support thyroid function as well.
Yeah, absolutely. That was a good one. So that brings us to Clint now.
Cool.
All right. So Clenbuterol, one of the things that I think is a consideration within Clenbuterol usage is kind of what you noted at the beginning, is taking progress without needing to add stimulatory based lipolytics in play, right? So basically going as long as you can to maintain the rate of progress without the deployment of this. And so once we kind of get to this point, we see Clenbuterol working as a beta agonist for fat loss and fatty acid mobilization, and being a very good next step from those first few that are, for a lot of people, are kind of like baseline in play deployments. And we'll often see kind of within the female realm, the Clen kind of touted as the non-androgenic deployment for tissue retention. So you see it kind of come on a lot of times pretty early on within preps for females. But I do think that the efficacy there is not quite as touted as like the way it's discussed. And I do think that we need to probably be focusing on managing the client from a fatigue management standpoint to maintain the rate of fat loss, but also understanding that this is a tool in our toolbox to help with the fatty acid mobilization.
Yeah. I mean, like you said, it's quite the aid, because for a lot of individuals that have to diet on low food and high output, you need something to foster that process a little bit, because food can only go so low and cardio can only get so high before you weigh out like, what is the worst driver of fatigue? Is it going to be training, or hey, I add a little bit of Clen in, is that going to do it? And Clen, I think, is fairly benign in that sense, in that you're able to still keep someone's food a little bit higher.
Yeah.
And that as a totality would drive less fatigue and make the burden of prep lessen and keep them really productive, right?
Yeah, for sure.
So, with Clen being deployed, we like you said, Luke, we have several different receptors on adipose tissue, all skeletal tissue, alpha receptors, beta 1, beta 2, beta 3. And Clen's primary role is on the beta 2 receptors, which it is present in skeletal muscle and adipose tissue. And Clenbuterol's direct action on your beta 2 receptors helps with liberalizing fatty acids. And that's going to be its primary role of just driving lipolysis and breaking down fatty acids. And it also has some role in probably decreasing protein degradation and increasing protein synthesis, like you said.
Yeah.
There was a study in men given a certain amount of clenbuterol. I forget the exact amount, but they measure like phosphorylation of mTOR, which is a pathway for muscle protein synthesis, and that was relatively fairly elevated within those subjects. So I mean, for a fat loss agent to say like, hey, this thing is going to cause muscle loss, and it is in fact probably has a little bit aspect for muscle preservation, which makes it a pretty unique agent in itself. And so I could see it's like deployment in the females where we don't want to use a lot of androgens, but you want something to drive fat loss, but also with muscle retention, like clenbuterol has a role there.
Yeah, for sure. I think one of the questions I get asked a lot is duration of use. Like, is the duration of use across the contest prep something to be concerned with? You'll see a lot of questions about like the cycle on, cycle off type of a construct within that. And just maybe kind of walking through, because the lack of need for that, but also like what duration of use for clientele often looks like, obviously contextually dependent, but probably more specifically on the people who are a little bit proclive to be lower food, higher cardio, because they're kind of be the extreme end ranges of that usage.
Yeah, I mean, with any of these drugs that we're using, you kind of want the lowest dose exposure for the least amount of time, right?
Yeah.
I mean, for anything to bring about the result. Of course, the reality of it is a lot of people are spending long durations on these. And I'd say at least for clenbuterol to, bring about there was so actually study looking at this for changes in receptor activation and muscle blood flow. And with clenbuterol's use, because what you notice with clenbuterol is that the shakes that you get kind of go away after a few days. So a lot of people, oh, my clen's not working, or you might not notice as much like heart rate elevation. And after taking clenbuterol, like after 18 days, there actually was a 50% like down regulation in skeletal muscle beta 2 receptors and a decrease in blood flow to muscle. But there's actually a like a 5-fold increase in blood flow to like white and brown adipose tissue. So what's indicative of that is like chronic use actually seems to improve fat loss around its action around adipose tissue, but you might lose some of the effects around skeletal muscle. So the aspects around muscle contraction, muscle protein breakdown, those might get a bit diminished, but the fat loss effects seem to actually get enhanced the longer you are taking it. Not that it's just continues to go on forever, but I'm saying that it's not in 2 days you need to come off clen because you're not going to be, it's not going to have actions on adipose tissue, right? So the idea of doing this cyclic approach with clen, it doesn't really hold up for what we see in the data. It would be deployed every single day.
Yeah, 100%. Entry dose for me, for a lot of people, is 20 micrograms. More so as a tolerance assessment for people, for especially those that are a little bit more anxiety driven, and kind of like an initial deployment for efficacy, and then going up in 20 microgram elevations from there. So 20 to 40, 40 to 60. Most of my people don't get above 60, but I have seen cases where 80 is warranted. But I don't think I'm ever taking anyone above 80.
Yeah, 80 is a good spot. And actually, I had just pulled up this one study that I had noted on here because because it's actually been used. Clenbuterol has been used in heart patients. So a lot of people worry about the impact on heart. And this was in this study, they used it in congestive heart failure patients. So patients that had heart failure, 80 micrograms per day of clen for 12 weeks. There was no effects on arrhythmia. Increased lean and fat mass ratios were noted in these individuals. So 27% increase in maximal strength and decreased in endurance, though. So that was the only aspect with CHF, but it was overall well tolerated in CHF patients. So you're looking at patients with heart failure taking 80 micrograms of clen for 12 weeks. So if someone in a healthy state easily could tolerate 80 micrograms of clen every single day for easily 12 weeks because we are not heart failure patients. But I've seen it even used in higher dosages in these heart patients as well, into the hundreds of micrograms. So, what we're proposing here is pretty low risk for Clen and bring about plenty of effect. But yeah, like you said, 20 micrograms is usually a starting point, and then 20 microgram increases as per needed. And then, if I don't need it in place, I usually pull it to give some break from it. So like during a peak week setting, I'm usually trying to pull out off much fat burners like that as much as I can, a little bit for fatigue management, but also just removes a lot of the variables going post show to be accurate with, what someone's maintenance is. It kind of starts defeating your purpose when someone's peeled out lean and you're trying to feed them more, but at the same time, you're taking something that expends more energy. It's like, would you do your peak week and do more cardio? Like probably not. Right. So if we can pull some of this out, that would be ideal. I've just tapered it down to like a low baseline dosage of like 20 micrograms.
Yeah. 100%.
Yeah.
Yeah, I think that's good for Clen, but I think that brings us to Mr. Alpha and Yohimbine, right?
Yeah. Yeah, with Yohimbine HCL. So, a lot of these we're looking for what are all the different pathways that we can really utilize here with Yohimbine being unique. It has some action on the beta 2 receptors like Clenbuterol, but also as an alpha 2 receptor antagonist. And when you have your alpha 2 receptors, an agonist work on like epinephrine, norepinephrine, it actually decreases free fatty acid liberation from tissue that has more alpha 2 receptors present on them. And where we see those is typically where you have more stubborn body fat, or you just have a genetic predisposition to store too. So like for females, typically this is in lower body areas, and males, usually it's more of that central adiposity. So you will probably have more alpha receptors around that. So when you have an increase in epinephrine, norepinephrine, like when you're doing cardio, it can diverge blood away from those tissues and not cause as much liberalization of those fatty acids. So where Yohimbine shines is an antagonist of that receptor. So it blocks the action, and it continues to enhance the effects of your beta 2 receptors. So there's a really great synergy that works there by blocking the alpha 2 receptor. Then you're taking something like a Clenbuterol that enhances beta 2 receptor action. So you have this enhanced effect to continue with liberalizing fatty acids for probably more troubled stored body fat areas.
Yep. And I think one of the things with Yohimbine is also considerations for removal towards the end, just from a peak week standpoint, like trying to nail the peak from a fluid aspect.
Yeah, it does. It can tend to hold a little bit of water with it. And so removing that out, and before even that, dosage considerations.
Yeah.
Yeah. I mean, usually it's moved from 0.2, was it point? I always make my decimals off. Yeah, 0.2 micrograms per what is it? I'm gonna mess this up. Don't let me mess it up, Luke.
Why don't we just start with where you dose it at as like the initial deployment?
Yeah, like 2 milligrams.
Yeah, 2 milligrams.
Yeah.
2 milligrams, and then going up a little bit from there.
Yeah, it's 0.2 milligram like per 100 kilogram, basically. So if you're a 100 kilogram individual, a peak dosing might be 20 milligrams.
Yes.
Okay. So it's body weight based. Again, I didn't sleep a lot, so my math was like, but anyway, but that doesn't mean that's what you need to go up to. That's just what they've seen in a study and they deployed and had effectiveness with, but it doesn't mean that a lower dose is not effective. So when you drive up that high, it does present some problems because Yohimbine can drive a lot of anxiety. And especially in prep when you're already using compounds that can cause more anxiety, and you're just in prep and you have the stress of prep too, it can really exacerbate a lot of that. So I would keep it low and move it up as you need, 2 milligrams and moving up in 2 milligram increments to bring about the effect that you want. Usually not, honestly, I haven't gone over 10 milligrams with anyone in a good while, with everything else being present. But with that in mind, it does seem to drive a lot of sympathetic tone with it and cause more stress in the physique. So pulling it before peak week happens is ideal.
Yeah, I think it's a little bit further down the list for me in deployment because of that anxiety issue. Like managing that for clientele across a contest prep is why, like, I'm probably trying to get more out of everything else before I'm deploying that. But it does make a lot of sense. So that's not to say that not use it or to be wary using it. It's just do be aware of the possible anxiety-based issues that could, kind of like we said, cause a bigger issue on the back end.
Yeah. So, I mean, those are the few compounds that I would have deployed. I mean, we might bring up ephedrine.
Yeah.
Have you ever used ephedrine on a prep?
Not for myself. I've used it a couple of times with clientele, not to real benefit over using just Clenbuterol with Yohimbine. It's not my preference. Most of the time people are going to have caffeine in play already anyways, because it's just prep. So we're going to see that already there. And then you'll have like the popularized ECA stacks that you'll see people use. But from a client management standpoint, I do think the impact anecdotally can be a little bit larger than using some of the others like Clenbuterol and Yohimbine.
So you see out of your clients just more of that kind of like Yohimbine driven, like stress and decrease in sleep and everything that goes along with it. Because I also like issue with ephedrine is that it does have a shorter half-life, because like Clenbuterol is like 34 hours. So once a day dosing is fine, but the issue with ephedrine is it's much lower. I think it's like 4 to 6 hours or something like that, to where you would need to do multiple dosings throughout the day to really bring about a lot of the effect. And sometimes that nighttime dosing, like it can really, or evening dosing, right, can really impact sleep. Of course, you would just pull it and just run it, morning, midday, and then cut it after that.
Yeah.
A lot of times, at least when I've run it on prep, and it was hard to access. So you'd go over the counter and get like Broncaid or Primatine, which would be ephedrine HCL, but it usually has that expectorant in it. Was it guafacine? I totally butchered the name, but yeah, you had that in there as well. But if you had any like, chest congestion stuff going on, it would could kind of impact you a little bit. But I mean, you were able to get like, hey, a legit pharmaceutical grade ephedrine via that way. You still can. So if like you have no access to Clenbuterol, I mean, it's there, and it has very similar actions of what you're trying to accomplish with it. Combined with caffeine, you could combine it with Yohimbine. Just realize you are adding a lot of stimulants on top of each other. So again, get the most from the least when you are deploying these things.
Yeah. And I think for the context of lipolytics, that mostly covers it. Yeah.
Yeah. Unless there's something, I'm sure there's some real foreign stuff out there.
Yeah.
Real back room, like bathtub batch stuff. But, I think those are the big rocks that we have good data on of what they do. And also just anecdotally what we've used with clients that work well, which is a pretty good list of items. The last one I would just to mention is, bringing in anabolics, because anabolics in themselves, and which are already going to be in place, they do upregulate beta-2 receptors. So it does have an aspect with the androgens of improving fat loss. However, these are not your primary fat loss tools. And so why I bring it up is because a lot of people in prep, the very end, you're like, I'm adding Halo in or whatever it is, whatever oral of your choice to get hard. And we were just talking about this, right?
Yeah.
To break down what that is and getting hard, it's usually about losing body fat, and your anabolics are not your best tool to lose body fat. They do have a slight supportive role, but they're already going to be in place. So you're not going to need to bring in a special oral that has more actions for fat loss. That doesn't exist. And then if it's water driven for hardness, well, there's things that we should be addressing before just dropping an oral to make you hard.
Yep.
I'm going to leave it at that because that I don't want to go into some dive of like, assessing your water levels. But from there, I think it's like painting the picture of when you'd be timing this to get the most out of it in a prep. If you have brought about all these compounds in place. So like kind of a hypothetical of what you might look like would be, getting up in the morning, you of course would be take thyroid hormone first because it can have some impact when you're having like fiber with a meal. So taking it fasting would be, ideal there. Clenbuterol, the timing's kind of irrelevant with it just because again, the half-life is like 34 hours. Now I will speak anecdotally. If you took Clenbuterol right before you went to bed, it could have issues with you going to sleep. So even though it has a long half-life, at the moment you take it, there is going to be an increase in the next few hours. So I would still time it first thing in the morning. But then the timing aspect of when of some of the other agents could be a little bit more important, one being growth hormone, because you are seeing a peak level in that 1 to 2 hours. So I would try to take your growth hormone as soon as you could when you wake up. And then, if you're getting to cardio within that 30 minutes to an hour mark would be kind of ideal. And then growth hormones actions can last for 3 to 4 hours after. So if it's even a window where you're going to have a longer fasting duration with it, I think you would pull out the most from fat loss that you're able to do.
Yep.
Same thing goes with yohimbine and caffeine, because those have also fairly shorter action windows. And you'd probably want to be taking these also within that hour before you're doing your fasted cardio. And that's how I would kind of lay all those out. So pretty much get up in the morning and take all your yeah, it's like, thanks, John. That was really insightful. Get up in the morning, take all your stuff as soon as you can, and then at least have probably 30 minutes before you're getting to your cardio. Timing, understand. I know you got to get on with your life. So if you need to get straight to your cardio, I get it. But ideally, if you had some little time window, like 30 minutes to an hour, that would probably be a little bit more ideal. Also, I wouldn't be trying to jump onto my cardio completely without any water, so if you had a little bit of time to hydrate, that also would probably be ideal just from a performance aspect of your cardio. Maybe you want to touch, Luke, just briefly on the cardio. I know we were going to try to dive into like all the cardio modalities and stuff, but I think just the type of cardio you're doing should probably be mentioned here.
Yeah, I think getting the heart rate elevation is important just first thing in the morning, right? So looking at trying to get that minimal 130 beats per minute. I do think the lower the impact, the better, which then kind of starts to bring in the conversation of, we see a lot of us using steps for our cardiovascular activity. And so we're using like higher rate incline treadmill based cardiovascular activity, which is a great option. I did my entire last prep on it. So it was literally the only cardio modality I used. I was having a knee injury I was dealing with. So it was just the easiest one that I could use without dealing with any issues there. I do like ellipticals. Some downfalls to ellipticals are you'll see people with like feet going numb, some lower back issues if they're not good at like controlling their hips / pelvis. But it is rather lower impact. And then kind of like the later two is like bike and Stairmaster. Pretty large impact from like a load perspective, and the carryover into training is what I find. So I am, for most people, trying to stay some sort of high-paced walk on an incline treadmill or elliptical-based work. But what you will see is as someone adapts over time, you get the cardiovascular adaptations. It is harder to get that heart rate elevation. So it may require slightly more to
Drug.
get that heart rate elevation.
Oh, right. Faster speeds.
Yes.
Don't just add more drug.
Yeah.
Can't get my heart rate up. No problem. Up your clean. No. Yeah, I agree. And I think it's kind of almost, if you want to call it, division dependent too, because 120-pound bikini girl walking on the treadmill isn't going to have a lot of output. Also, is not going to be extremely fatiguing for that individual. Recovery is going to be improved, especially for your females. So if you are needing to move them to a higher output cardio like elliptical or stairmaster, I find it's not as impactful to their training performance.
Yep.
If you're like a 250-pound bodybuilder on the stairmaster, like this is going to be fatiguing, like absolutely. So
Yeah.
there's a weighing of variables that you have to put out there. Like the stairmaster has like a systemic kind of fatiguing effect, while the spin bike, the issue with that is it's kind of a localized fatiguing. Although it's like all concentric work, you have to pedal the thing pretty damn fast to get your heart rate up because you're only moving just your legs, opposed to like the other aspects have higher load, right? So you don't have to move as fast. So spin bike, man, you gotta turn it up and get pretty quick on it, which causes a lot of localized fatigue.
Yeah.
So I think for a larger individuals, your incline treadmill is probably the most forgiving to give you the just as much output for the least imposing on fatigue. Of course, your duration might need to increase a little bit with it because of that. Now, that would be my ideal in a situation like that, because you're really trying to, for what we want for cardio, we're not looking to run marathons and have all these cardiovascular adaptations. We're just looking to bring about the calorie deficit with the least imposing aspect on fatigue and resistance training. And so if you can just do it through just treadmill walking and then the rest of the day, your steps, that would be kind of the perfect, I think, situation. Doesn't always happen though. You might have to drive someone up a little bit in higher output because of time.
Yeah.
I have individuals where they sit a job all day. There's no way they can get steps in. You're kind of stuck with having to push them a little harder output wise in cardio, but at least you have an approach, right? Like you laid out, of where we should be moving modality wise to try to not cause as much fatigue and impact their training.
Yeah, for sure. But I will say, if you want a picture for the gram, 5 minutes on the bike for a quad pump is
yeah, fair enough. Like, yeah, I started doing my hit on the Stairmaster, for the heart benefit, right? Man, I mean, even with that in the bike, either one is like the quad pump is just nutty. And honestly, I recover pretty quick from it. Like, it doesn't seem to impact like leg training.
Yeah.
For like low volume hit. Like,
low volume hit.
Yeah, to context for y'all, it's like 4 sets of 1 minute at like 80% effort. So I'm not trying to sprint on this thing.
Yeah.
But yeah. That's quad pump city, right?
Yeah. Well, I think that wraps it up. So if you want to kind of give them the quick outro and then we'll head on.
Right on. Yeah. So you guys, using fat loss agents, just remember there's an order of operations here. These can bring about the extra percent needed, but again, you still have your major levers to pull on to drive fat loss along the way. But anyway, appreciate y'all tuning in. Any comments, questions, if you're watching YouTube, leave them down below. Happy to answer those for you, and talk to you next time.